Who are we? We're not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learned what so many of us have forgotten. The value of every single day, the preciousness of every breath, of every heartbeat. And we make tears, tears of thanks for the release from pain. And then there is hope, the hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Naliaka, Ochieng, Kevo, and Mwende. And that is why we're not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life. Who are we? We're not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learned what so many of us have forgotten. The value of every single day, the preciousness of every breath, of every heartbeat. And we make tears, tears of thanks for the release from pain. And then there is hope, the hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Naliaka, Ochieng, Kevo, and Mwende. And that is why we're not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life. Who are we? We're not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learned what so many of us have forgotten. The value of every single day, the preciousness of every breath, of every heartbeat. And we make tears, tears of thanks for the release from pain. And then there is hope, the hope parents have for the happiness of their children. You see, We don't have a strategy. We have a cause. We don't have a vision statement. We have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Naliaka, Ochieng, Kevo, and Mwende. And that is why we're not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life. Who are we? We're not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learned what so many of us have forgotten. The value of every single day, the preciousness of every breath, of every heartbeat. And we make tears, tears of thanks for the release from pain. And then there is hope, the hope parents have for the happiness of their children. You see, we don't have a strategy. We have a cause. We don't have a vision statement. We have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Naliaka, Ochieng, Kevo, and Mwende. And that is why we're not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
Esteemed members of the profession, good evening. Welcome to today's session. If you can hear me, kindly just say hi on the chat. Let us know which branch you're joining us from. All right, thank you, Dr. Liz. Thank you, Dr. Frederick. Asanteni sana. Thank you, Dr. Nadia from Nairobi branch. Dr. Anthony, Dr. Esther, Dr. Titania, karibuni sana. Thank you for joining us today. All right, so today's webinar is on management of moderate pain, introducing Cipladon Plus. And this webinar is sponsored by Cipla. And our speaker today is Dr. Esther Nafula Nekesa, who's the head of palliative care unit at the Kenyatta National Hospital. So just before we start, I'll take you through a few ground rules. And first, it's to thank you for participating in this session. And I'll also remind you that you'll be muted during the entire course of this session. So if you have any questions, kindly use the Q&A chat button that is available there. If you have any, and then for all the PSK members, if you have not done so, kindly subscribe on the PPB portal. For ease of getting the webinar, just search for these keywords, moderate or pain. You should be able to see management of moderate pain. And kindly check on the date. It should show the correct date on the side. Also to remind you that this webinar is being recorded and it will be made available on the PSK YouTube channel later. So for the agenda, we'll have our facilitators, Dr. Esther Nafula from Kenyatta National Hospital, and then thereafter we'll have a speaker from CIPLA, Coletta, and then thereafter we'll have a Q&A, then the closing remarks. So if you have any questions, kindly utilize the Q&A chat. They'll be responded at the end of the session. So at this point, I'd like to welcome our speaker for today, Dr. Esther Nafula. Dr. Esther, if you can hear me?
Yes, I can hear you. I hope you can hear me well.
Yes, loud and clear. Can kindly share your slides.
So this evening, we are going to talk about management of moderate pain. And we're going to take about half an hour to talk about moderate pain. The main objective is actually to discuss the choice of analgesics for moderate pain. By the end of this session, I expect that the participants will have learned something new or refreshed their knowledge on how to identify and manage moderate pain. So we'll start with a case. Please pay attention to the case because I'm going to ask some questions after that. I would like you to type your answers to the chat. So Kevin is a 38-year-old male patient with a diagnosis of metastatic cholangiocarcinoma who presents with abdominal pain radiating to the back. Kevin rates his pain at 6 out of 10 on the numerical pain scale. So he has been on chemotherapy, but this has been withdrawn because he's having disease progression despite treatment. And he has overall poor performance status, so he's not able to be given treatment. So for his pain, he has been taking over-the-counter medications. So Brufen, paracetamol is what he takes sometimes, but he reports that he only has fair control over his pain. So his oncologist saw him and gave him a prescription of tramadol, but he has not started it yet because he's afraid that if he'll get used to the painkillers. So he's referred to you to review his pain. What are your first thoughts? What are your initial thoughts about this case? So these 3 questions, I want to give you about 30 seconds to 1 minute for you to just answer in the chat. What are your initial thoughts about this case? Do you think that opioids are appropriate for his pain? And what medication would you recommend? Now that he has been referred to you, what would you give him for his pain? So feel free to type in the chat or the Q&A. So you can type what you're thinking about the patient's pain, what you're thinking about the medication you would recommend for him, and whether you think opioids are appropriate for his pain. So we have 1 minute for that. All right, so I will read through the answers that are coming through. So opioids are appropriate. A mild opioid like tramadol is appropriate. Someone says the patient needs pain medication and opioids are indicated. Tramadol would be the drug of choice. Opioids are appropriate for him. Quantify this pain on a scale of 1 to 10. Check adherence and dose appropriateness of existing medications. I will stick with tramadol. Looks like a palliative care patient. We would recommend opioids. Opioids are appropriate for his pain. I would recommend that too. So there's someone also who says a combination of painkillers would be good for him. So it is chronic pain. I recommend opioids. At this stage, opioid is not recommended. The patient has moderate pain. I would recommend morphine if opioid naive, but at a low dose. Good for pain management, but they could lead to addiction. That is opioids. Opioids are appropriate. First line, like paracetamol, considering the pain is 6 out of 10, we would go for mild opioids. Someone has said that is visceral pain, so we can do opioids and adjuvants. Brufen would be appropriate except for the GI side effects. So, okay, I see that we all seem to agree that this patient would need opioids for his pain and that he would need a combination of analgesics. So what is pain? Pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. So what we need to remember when we have a patient with pain is that pain has the sensory or the physiological component, and then there is the emotional component of how we respond to the pain, the distress that comes with the pain. Pain is also what the patient says it is and occurs whenever the patient says it does. So the golden rule about pain is to believe the patient when the patient says they're in pain. They're the ones experiencing the pain, so we should be able to actually take a good history about pain from the patient, and we should believe what they tell us. So pain is classified in very many ways. We can classify it based on the mechanism as either nociceptive or neuropathic. And nociceptive pain would generally be somatic or visceral, and it would come from muscles, hollow organs, and smooth tissues. And neuropathic pain would be pain that comes from nerve damage or infiltration of nerves by a tumor. Then we can classify pain based on the duration of the pain, acute or chronic. And generally, acute pain is considered to be pain that lasts up to the duration of healing, which is 3 months. And chronic pain is any pain that will persist beyond the healing period, which is 3 months. Then we can also classify pain based on the etiology of the pain, what is causing the pain. Like Kevin, we can classify his pain as cancer pain. We can classify pain as traumatic, as post-operative, depending on what has caused the pain. Now, when we are assessing pain, it is important for us to evaluate the pain in a systematic manner to try and establish the cause of the pain. So when did the pain start? Where is it? Where does it radiate to? What is the nature of the pain? We want to use validated scales to provide a baseline for analgesia and healing evaluation. So we have tools that are used in pain assessment. Like for Kevin, we've said that he rated his pain on a numerical pain scale. So we want to use the same scale for the same patient during assessment and reassessment. Do not introduce new scales every time you're assessing pain, because when we teach the patient the scale and we use the same scale, we are actually able to assess whether our treatment is working or not. We need to document the findings so that when our colleagues are reviewing the patient or the patient says they still have pain, it is easy for them to know this pain was rated on a numerical rating scale. It was 6 out of 10. This is what we thought about the pain. This is the treatment that we gave. So what is happening today? Then assess the degree of expected or actual pain from procedure, surgery, injury, or disease. So we are having a patient here that has cancer and it is metastatic. So we are expecting that the degree of pain will increase over time because we are not able to cure the illness. If a patient is post-operative, for example, we expect that once healing starts to happen, the patient's pain will start to reduce. So this is the numerical rating scale. It is one of the validated tools for assessing pain, and we use it for literate patients and patients over the age of 9 years who are able to count. So it is an 11-point Likert scale that starts from 0 to 10. 0 is no pain, 1 to 3 is mild, 4 to 6 is moderate pain, and 7 to 10 is severe pain. Please remember this classification of pain, because when we go to the pain management ladder, we actually use this rating to decide which analgesics to give to the patient. So the WHO ladder is a 3-step pain relief ladder. It has been in use since the 1980s. Actually, this ladder was developed for management of cancer pain only, but with time we have adopted it for use in other chronic pains and acute pain, because following the principles of pain management that were developed by WHO in 1981, over the years, research has shown that 80% of patients actually get relief of their pain. So we are able to accurately assess and reassess pain. And the goal is actually not to have 0 pain, but to make the pain tolerable. If our patients say their pain is 6 out of 10, and we are able to control the pain well enough that we reduce that pain up to 2 out of 10 or 3 out of 10, and the patient is able to function, then we have actually achieved our goal in pain management. So this ladder has 3 steps, where step 1 is for mild pain, which we said on the numerical scale, patients will rate that pain from 1 to 3. So we use a non-opioid, and non-opioids in this instance are non-steroidal anti-inflammatory drugs and paracetamol and aspirin. So they are drugs that are not opioids, and they are useful for mild pain. When we come to step 2, we use weak opioids, and weak opioids in our setup, we have codeine, tramadol, and low doses of morphine. So moderate pain is rated between 4 and 6, and we would choose a weak opioid. Now, when you see the ladder, we have said that for the weak opioid, you can combine it with an non-opioid and an adjuvant, with or without an adjuvant. For step 1, we will use non-steroidal anti-inflammatories, and we combine them with adjuvants. Now, for step 2, where we have weak opioids, you can give the weak opioid and the NSAID or paracetamol separately, but we also have combination medications. And the base of the combination medications is actually paracetamol and a weak opioid at low doses. And the advantage of that is that you have 1 pill or 1 tablet that can still be able to give you multimodal analgesia. And we are able to add an adjuvant depending on the type of pain that the patient is having or the response that they will have to the medication. At step 3, we want to use a strong opioid, and in our setup, the strong opioids we have is morphine, fentanyl, oxycodone. Hydromorphone and buprenorphine are not readily available. So again, at step 3, we can use the strong opioid with a non-opioid and with an adjuvant, with or without. So you remember the answers that you gave in the chat for Kevin. We had varied answers that yes, you would choose a weak opioid because his pain is moderate, and we got answers that you can use multimodal or combination analgesics, and all those answers were correct. And some of you even said that we can actually give an adjuvant. So Kevin's pain responds to your choice of drugs, which in this case was a weak opioid with or without paracetamol, and you could give him either a combination dose or a single agent. But after 2 weeks, he starts to report that he's having breakthrough pain. So he tells you that I'm taking a combination of codeine and paracetamol every 8 hours. And at hour 6, I start to experience pain. This is at the end of the dose. So I have 2 further questions for you. What are the options for managing his pain at this point? He's not responding to your weak opioid anymore or the choice of your drugs. And what can you add for his treatment? So I'll give you 30 seconds to type in the chat or the Q&A. So he's getting breakthrough pain. What are your options now? And yeah, what else can you add to the treatment? Please type your answers in the chat. I'll start going through them as we respond. So now use an extended release opioid regularly and add a PRN. Then a non-opioid painkiller, add paracetamol, add an adjuvant. We can switch him to morphine solution. I would not recommend NSAIDs because pain management is going to be long term, but we can do opioids and selective COX inhibitors. So all those answers are correct, that we need to explore the pain. So first of all, ensure that the patient is taking your medication as prescribed, and then try and reassess the pain. What type of pain is he having? Could there be a neuropathic component? Can we give him an adjuvant? Can we switch to a strong opioid? Can we optimize the dose of what we have? And yes, the comment that this is going to be long-term pain is actually true because this is cancer pain. So this is a patient that you want to be on pain medication regularly. And in palliative care, we say PRN stands for patient receives nothing. So please, for patients with cancer, patients who need long-term pain management, we want to avoid giving them PRN medication because sometimes they end up being in pain. They do not take that medication at all. So let's go back to the presentation. So multimodal analgesia means that we choose analgesics that have different mechanisms of action. And the advantage of that is that it leads to better pain control because the medications work on different pathways. For patients who are postoperative and we are able to give them different classes of analgesia or analgesic combinations, they are able to ambulate earlier, therefore they are able to be discharged earlier from hospital. These medications can also be taken orally, so it is very easy to control the pain for our patients. Adjuvants, you have mentioned adjuvants as an analgesic choice for our patient, and adjuvants are basically medications that potentiate the action of analgesics. Their primary role is not to manage pain, but they work on pain pathways. And the common classes we have is antidepressants, anticonvulsants, steroids, local anesthetics, and biphosphonates. And the indications vary depending on the nature of the pain that the patient has come with. So I will not go into so much details about the adjuvants. Today, what I want you to gather most is just how to approach the patient with moderate pain. So we are going to a different type of pain. We have managed cancer pain very well. Now we have Carol, who is a 52-year-old female who has been admitted for a hysterectomy due to abnormal uterine bleeding. So she undergoes a successful abdominal hysterectomy. The report from theater is that she received anesthesia, inhalational anesthesia, a neuromuscular blocking agent during the procedure, and she was also given 10 milligrams of morphine IV prior to anesthesia reversal. So you meet her in the postoperative room and she's restless and she tells you that she's still in pain, and she rates the pain at 7 out of 10. We'll look at the scales that we use for patients in the postoperative recovery room. But just note that this patient has received anesthesia, has received a neuromuscular blocking agent. She has also received morphine, and now she tells you that she has pain that is 7 out of 10, which is still severe pain. So again, let's type in the chat. What would you recommend for her pain when she's in the recovery room? And later on, after we are done with anesthesia, we are back to the ward. In the next few days, what would you recommend? So let us start with the recovery room. She has pain now, 7 out of 10. What would you recommend? And then what would be your pain management plan as we are thinking of discharging her post the procedure? Okay, there's a request to send the slides. We will coordinate. So, Ketes, someone says we can give her Ketes. Paracetamol in the recovery room, increase the dose of morphine. What would you give her after? In the recovery room, I agree. We need to give her an opioid, so fentanyl followed by tramadol and paracetamol. Increase the dosage and add an adjuvant. Any more responses to that? Paracetamol. So what we need to note now, the previous patients that we have discussed, we were dealing with chronic pain. Now we are dealing with acute pain. So in the post-anesthesia recovery room, sometimes our patients are drowsy, so they may not be able to coordinate very well. So sometimes we use the numerical rating scale, but we can also use the Wong-Baker Faces scale. This is a scale that has been in use for many years. It's used for children from the age of 3 and above. It's been validated. So it has faces, and the patient can point to you the face that corresponds to their pain. So our patient who is in post-recovery would likely point to a face between 6 and 8. And if the patient is able to use the numerical scale, we can use that. But we can also use the Wong-Baker Faces scale. So for acute pain management, acute pain is often nociceptive, and it's often associated with tissue damage. It responds to both non-opioids and opioids. And the common adjuvant that you would want to use for acute pain, like in a post-operative setup, would be infiltration of local anesthesia or regional anesthesia as part of pain control. So mild to moderate pain will respond well to NSAIDs and paracetamol, and moderate to severe pain will also need opioids depending on the cause of the pain. So in this case, when we are dealing with post-operative pain, we will want to introduce our patient to weak opioids, but we will do that for low doses and for short durations of time. Part of the plans for going home were weak opioid on discharge with paracetamol, and that is a very correct answer. And we find that for many patients who are post-operative, we tend to give them combination analgesics. So as I mentioned earlier, the combination analgesics will often have paracetamol and a weak opioid. So you'll find your patient going home with a formulation that has a codeine, or it has tramadol and paracetamol. And in acute pain, we want to use opioids for a short time. When we compare Kevin and Carol, Carol is going to be on analgesics for a short time because we expect that healing is going to happen within a week or so. She'll be off analgesics. For Kevin, who has cancer, we expect that the pain is going to increase and is going to be on analgesics for a long time. So the rules for using opioids in acute pain is that we want to give them for a short time. So give short-acting opioids and use weak opioids at the low doses where there's a clear indication, like this is post-operative pain and the patient has rated it as severe. So we expect that in a few days, the pain will become moderate and mild. So we go down the ladder. Use the lowest effective dose and use for short periods, not more than 3 days, and refer the patients appropriately for pain management. If the patient's pain is increasing, this is a post-operative patient, within a week you find that they're still having pain or they're still reporting that they're having moderate to severe pain, you might want to see if there's anything interfering with the healing process or if the patient has developed complications after surgery. Now, remember, when we are managing pain, it's not just about giving a prescription. We said that pain has an emotional component and it has a physical component. So the painkillers or analgesics will address the physical component, but there is more that happens when a patient is in pain, especially patients with chronic pain tend to have what we call total pain. They will have psychological stress associated with the pain. They will have social anxieties because their pain is hindering them from their activities. They will have financial problems associated with treating illness and trying to be in and out of hospital to establish the cause of the pain. They will have some spiritual aspects of pain as they are wondering, why am I in pain? Why am I sick? How long is this going to go on for? So as we manage pain, please remember that it's a multidisciplinary approach. It's not just about giving a prescription of analgesics, but also trying to get to the root cause of the pain and trying to address the other issues that might improve the patient's experience of pain. So we would strongly recommend that when we assess pain, we look at the other components. How is the psychology of the patient? How is their social support? What is the input of the family? What does the patient believe to be the cause of the pain? In our setup in Kenya, a lot of patients will believe it is witchcraft. So how are you going to handle those other issues apart from just giving the prescription? So there are other interventions that have been used to manage pain. This includes cold compress and ice packs and sometimes even heat therapy. For patients with fractures, we might want to immobilize the limb. Sometimes we do limb elevation where there's swelling as much as we are giving analgesics. We want physiotherapy and occupational therapy to help us to mobilize patients post-operatively, patients with injuries. Some techniques like yoga, hypnosis, guided imagery are distraction techniques that help the patient to focus their attention away from pain. And even things like music, reading, there are distraction techniques that can help the patient divert their mind away from pain. We have acupuncture and massage. Then we have cognitive behavioral therapy. So for psychological and social factors, we might want the input of the psychologist and we might want our patient to have sessions to help them deal with their diagnosis, their prognosis, and other social issues that come about because of pain. So in our final reflections, take-home messages. When we are having a patient with pain, the first thing we need to do is to have a focused clinical assessment. So a focused clinical assessment includes taking a detailed history. In that history, you try to identify the underlying causes of pain. You try to establish the pattern of the pain, the factors that improve or worsen the pain. You try to establish what medication is the patient taking. Is it over the counter? Is it prescribed? What fears and anxieties does the patient have? What do they believe is causing their pain? And how can we intervene? Then the next step is to achieve pain control, and we achieve pain control by choosing the appropriate analgesics. So today we are talking about moderate pain, and I think the message I want to emphasize is that we can use opioid combinations for moderate pain. If it is acute moderate pain, use these combinations for short durations of time. If it is chronic pain and it's due to cancer, we might want to keep the patient on the opioid combinations for a longer time. If it is chronic pain that is not due to cancer, please refer these patients to a pain specialist early so that they can get interventional pain management like regional blocks to control their pain. The aim of pain assessment is so that we can identify the underlying cause and offer disease-specific treatment. Remember, pain is the body's way of telling us something is wrong, so pain is a symptom. There is often an underlying cause of pain. In very rare circumstances, can we say that we are not able to identify what is causing a patient's pain? So in identification, we want to send them for the relevant investigations. We want to identify the diagnosis and we want to give disease-specific treatment. As much as we will prescribe analgesics, we need to give chemotherapy, radiotherapy, we need to give surgery, we need to give options so that we are able to actually cure their disease or manage their disease and therefore control their pain. And finally, remember to educate your patient. Do not just give the patient a prescription and tell them take this medication every 6 hours or every 5 hours, and you've not educated your patient on their cause of pain, on the side effects of the medication, how long they're going to be on those medicines, what to expect, even what is their disease and how are we going to treat it. So part of this patient education actually helps us to manage the emotional and psychological component of pain, because patients in pain often want an answer when they come to us. What is causing my pain? How long am I going to be in this pain? So we should be able to take them through the investigations that we want to do, the results, the treatment plan, and even how soon they should come back for a consult in case their pain is not improving. Thank you. I'll stop sharing my screen now and hand it over back to the moderator.
Right. Thank you so much, Dr. Esther, for that insightful presentation. For those who joined us late, Dr. Esther is the head of palliative care unit at the Kenyatta National Hospital. So at this point, I'd like to welcome Coletta from CIPLA, who will be doing a presentation. Meanwhile, kindly stay on the meeting, ask your questions. They'll be responded to at the end of the session. Coletta, if you can hear me.
Yes, I can hear you.
All right. Thank you. You're welcome.
So, good evening, everyone. We have had a very beautiful session with Dr. Esther Nafula. Thank you so much for taking us through pain, how to assess pain, and the different drugs that we should administer, after assessing the pain. Right, so today, CIPLA is introducing to you Cipladon Plus, for when it's that kind of pain. Cipladon Plus is an analgesic, a multimodal that contains paracetamol, 450 mg, codeine, 10 milligrams, caffeine, 30 milligrams, and doxylamine, 5 milligrams. So we've talked, or we've seen different kinds of pain, and encountered patients who come in with shoulder pains, a severe or an intense shoulder pain, right? We've also come across patients who come in with dysmenorrhea or period pain. We've seen patients as well who come in with migraine or tension headaches. So the question I'm throwing to you today is, did you know that 3 to 4 out of every 10 patients who receive pain medication never receive adequate pain relief? And we'll be able to know why as we continue with the presentation. So Dr. Esther did talk about the WHO pain ladder. So I will refer to the WHO pain ladder throughout my presentation. And the reason why WHO came up with this ladder is so that we can be able to know which pain medication or which drug we can use at the respective steps. This step 1 that talks about mild pain. This step 2 that talks to mild to moderate pain. This step 3 that talks to moderate to severe pain. And then step 4, severe to very severe pain. So we know that pain management is really difficult because of the pathophysiology of pain. Responses up to different patients. Again, in reference to the WHO ladder, we are advised on the medication to use at each and every step. We can use analgesics, we can use NSAIDs, we can use opioids, we can use adjuvants, all for the treatment of pain. And then depending on the type and severity, of the pain, we can use local anesthetics, we can use transdermal patches. And then we'll see that combination of analgesics and opioids do actually bring in a paradigm shift, and especially to low or middle income countries. So what is pain? I think Dr. Esther has really done a good job in classifying pain. So depending on the duration of the pain, we can classify pain into two, acute pain and chronic pain. I'm going to focus more on acute pain. So acute pain can be divided into four or into three. There's mild pain. So mild pain, in definition, is pain that doesn't interfere with your daily activities. And so under mild pain, there's non-inflammatory pain. And on non-inflammatory pain, we can administer paracetamol, for example, Cipladol. When there's inflammation, we can administer NSAIDs, for example, ibuprofen. Right, so moderate pain. By definition, moderate pain is pain that may interfere with your regular activities. And for patients who have moderate pain, we can give weak opioids or multimodals, for example, Cipladol plus, right? For severe pain, just like doctor has told us, this is pain that keeps you from doing your regular activities. And medication you can give at this particular step is strong opioids, for example, morphine and oxycodone. When we have severe pain, this is the worst pain that you can imagine. We can give our patients strong opioids, and we can introduce interventional treatment. For example, yoga. Ice. We can use ice compression, just like Dr. Ria has told us. So the good news is, we have Cipladol and Cipladol in Kenya. And using the WHO pain ladder, it is easy to identify where to administer Cipladol and Cipladol plus. So for mild pain, right? Again, defining mild pain, this is pain that doesn't interfere with your daily activities. We can administer Cipladol. For moderate pain, this is where we introduce weak opioids or multimodals, and this is pain that may interfere with your regular activities. So for moderate pain, we do administer Cipladol plus. We can be able to see clearly where to administer Cipladol and Cipladol plus. So today we're introducing to you Cipladol plus for when it's that kind of pain. So what is Cipladol plus? Cipladol plus is a potent one-of-a-kind combination of analgesic, antipyretic, and antihistaminic agents used for the treatment of acute moderate pain. So the active ingredients include paracetamol, that is 450 milligram, codeine phosphate, 10 milligram, doxylamine phosphate, 5 milligrams, and caffeine, 30 milligrams. It is classified as an analgesic combination, and it is scheduled as a prescription-only medication. You can see Cipladol plus. This is how the pack looks like. A pack contains 20 tablets. Again, it is really important to be able to differentiate Cipladol and Cipladol plus. We do dispense Cipladol for mild pain. Cipladol plus is a prescription-only medication that is used for the treatment of moderate pain. For the indications for Cipladol and Cipladol plus, using the pain scale, so what are the indications for Cipladol? You can give Cipladol for fever, headaches, toothaches, sore throat pain, period pains, rheumatic and muscle pains, backache, earache, relieving of aches and pains associated with colds and flu. For Cipladol plus, the indications include tension headaches and migraine. There's menstrual pain or dysmenorrhea, that is cramps and pelvic pain. There's neuralgia, sharp shooting pain, often due to an irritated or damaged nerve. Post-operative pain, like for our patient Carol, and that is abdominal pain following a C-section procedure. So Again, this is our pack. Cipladon is actually manufactured in Africa for Africa. It is manufactured in Uganda, a neighboring country, in our plant that is CGMP certified, reassuring you the strength, the quality, and the purity of Cipladon Plus. Again, if you go through the active ingredients, there's paracetamol 450 milligrams. It acts as a pain reliever. We have codeine 10 milligrams. Codeine is converted into various metabolites, including morphine, and acts as a powerful pain reliever. The antihistamine, that is the doxylamine 5 milligrams. It's a first generation antihistamine. It blocks GABA reuptake, resulting to a calming sedative effect. And then the caffeine 30 milligram, it enhances the pain relieving effects for paracetamol. So why would you choose Cipladon Plus? One, it is manufactured in a plant that is CGMP certified. Two, it is powerful. It is a very unique combination that offers higher efficacy. I'd mentioned Cipladon Plus is manufactured in Africa, in Uganda, CIPLAC UCIL. So quality control checks have been put in place from, procurement of raw materials all the way to the final product. So we are providing quality and affordable medicines in Africa. One of the during the COVID period, we realized that Africa really needs to be self-sustaining when it comes to medication. So this is one of the many drugs that are manufactured in Uganda for Africa. So the indications, as I conclude, we have dysmenorrhea, neuralgia, migraine, tension headaches, and postoperative pain. So for dosage and directions for youth, adults, and children 12 years and above, you take 2 tablets every 4 hours as needed. You're not supposed to exceed 8 tablets per day, and you cannot use for longer than 10 days without consulting the patient consulting their doctor. Right, so Cipladon, the trade price, maybe that will be your next question. The trade price, it's 376 per pack, and the RRP is, the recommended retail price is 500 per pack. So thank you. Back to you, Dr. Hezron.
All right, thank you so much, Coletta, for that presentation. So we'll now be moving to the Q&A session, and I'd like to start with Dr. Elizabeth, who's asking, how do you monitor pain tolerance and perhaps addiction to some stronger medications? So maybe that will be answered by Dr. Esther.
Yeah, so opioid analgesics, the way they work is that patients develop tolerance within a period of 2 weeks. And tolerance is a physiological phenomenon where they require a higher dose to achieve analgesia. So that is normal. When you start opioids, especially for chronic pain, patients will need a higher dose within at least 2 weeks to 1 month. We need to increase the dose. That is normal. What we need to differentiate it from, though, is addiction, because now addiction is where there is persistent desire or efforts to use an opioid that is not needed. For example, now a patient who has, like the case we used, the patient was post-operative, we've started them on an opioid analgesic. They are now healed. They don't have pain, but they go out of their way to look for an opioid. Now that becomes now addiction, which in itself is a psychiatric disorder, and we need to be able to identify. And maybe a few pointers on how to identify a patient who is likely to have addiction is that first, the patient does not need an opioid, but they go out of their way to look for an opioid. So it means they actually no longer need it. Then their continued use of the opioid will decrease their quality of life. It causes social isolation. They are not able to function, and they are not. They develop withdrawal symptoms when they do not get the opioid. So it is just to look at the behavior. So a patient who has pain, for example, a patient with cancer pain, coming to ask for an opioid prescription, maybe because their opioid has run out, is not equivalent to addiction. But a patient who will move from one hospital to another, trying to get opioid prescriptions from different doctors and using opioids at very high doses could be a red flag for addiction. So when we are starting opioids, that's why, if you remember very well in my presentation, I emphasized that for acute pain, we want to use opioids for a short time. 3 days, 3 to 4 days, we want the patient to be off opioids. For chronic pain, if it is not cancer pain, please, as you start the opioids, refer the patient for a pain consult so that we can get a long-term solution. If it is cancer pain, that is the only diagnosis where we are not very concerned about addiction, because the pain is so bad and sometimes the prognosis is poor. So we are more concerned about quality of life among cancer patients, especially when it is advanced. Thank you.
All right, thank you for that response. The next question is from Dr. Ahmed Noor, who says, thank you so much for the good presentation. And he gives a case of an elderly man who presents with the lower limb swelling of the left leg, and then a diagnosis of cellulitis is reached after ruling out DVT. He rates his pain at 8/10. How would you recommend, what would you recommend for pain management?
So cellulitis, the pain is likely to be inflammatory in nature. So again, your best choice of medication could be an NSAID, as you give also antibiotics to reduce the pain. But if the NSAID alone is not controlling the pain, there's a role to use a combination like Cipladon Plus or any other combination that has a weak opioid and paracetamol. But remember, again, cellulitis is inflammatory, so we are expecting that healing is going to happen. So if we use a weak opioid, we're going to use it for a short time as we treat the underlying cause, which is an infection. Thank you.
All right, thank you for that. Maybe this question will go to Coletta. Someone is asking, where can they find this product?
Okay. The Cipladon Plus is available in all our channel partners. You'll find it at Nila. You'll find it at Symbio. You'll find it at basically all our leading channel partners, our distributors. It's available. Krishna, Makadara in Mombasa, Transchem. Yeah.
Okay. Maybe there's one
Med.
Is it also available at Meds?
At Meds? Not yet. It's not available at Meds.
Okay.
Yes.
All right. Thank you so much for that. Dr. Esther, maybe another question for you. There's a question on how do you treat back throbbing pain?
How do we treat?
Back throbbing pain.
Back pain.
Yes.
So again, back pain, you need to establish the cause, because sometimes it is degenerative diseases of the spine. It could be muscular in nature. So I think the first rule, again, as we assess, is to try and establish what is causing the back pain. Is it arthritis? Is it muscular pain? Is it neuropathic pain? So then we would choose the analgesics depending on the degree of pain. But again, for chronic non-cancer pain, which is the category where chronic back pain falls under, we really try to avoid giving opioids. So the mainstay treatment is NSAIDs with adjuvants, and again, just trying to treat the underlying problem.
All right, thank you for that. Maybe the final question. that comes from Dr. George, who's asking, what about in the case of palliative care patients with consistent chronic pain? What measures do you put in place?
So for palliative care patients with chronic pain, as I said, if it is cancer pain, the rules in managing chronic pain for palliative patients, first is we try to establish the overall prognosis of the patient, like what are we expecting, how much of a lifespan does the patient have, and how can we improve their quality of life. Because once a patient comes into palliative care, our goal is to improve the quality of life. So if pain is a big problem, then we have to control that pain by whichever medications are available, so that we are able to improve the quality of life of the patients. So in my experience, most of the patients in palliative care with pain will be on strong opioids, because most of the time the diagnosis is actually life-limiting or life-threatening. So as we give them opioids generously, we also try to see long-term, how can we control the pain? Because some of our patients do not have cancer, like we get a lot of patients with chronic pancreatitis. For those ones, we try to keep them on opioids for a short time. Then we try to see whether we can optimize adjuvants and whether they can actually qualify for procedural pain management. Thank you.
All right, thank you for that. Maybe just the last one that I've seen come. There's one from Dr. Julius who's asking, how much influence does religiosity have on chronic severe pain?
Religiosity, that is spirituality. Spirituality does have a big influence, because a lot of patients with chronic pain, there are some beliefs that are associated with pain. So the common one, for example, there are people who believe that they are sick because it's a punishment from God. Others believe it is a test from God, it's a test of their faith. Others will believe that it is they can pray or they can meditate and the pain can go away. So understanding what the patient believes is actually very important as we start to prescribe treatment, because for meditation, for example, is one non-pharmacological way of managing pain. Then just understanding the space where the patient is can also help with coping with their illness. Because, for example, if someone believes that they are in pain because God is punishing them for things that they have done in the past, you might want to link this patient up with the chaplain. Some of our institutions, like in KMH, we have chaplains that are able to actually help us sort out these spiritual issues. And it's important also because sometimes you'll prescribe medications and your patient will decide to go for prayers and throw away the medication. So it is actually good to understand the belief system of the patient. What are their core beliefs? What religion do they subscribe to? And really, what do they believe is the cause of their illness or their pain, and what is their attitude towards the medications that you want to prescribe? Thank you.
All right, thank you so much for that response. Maybe one question for Coletta, or maybe anyone from CIPLA. And the question is on Dr. Brian is curious on how the antihistamine contributes to the effectiveness of the Cipladon plus combination.
Hi, okay. Before I answer that, I would like to confirm that Cipladon Plus is available at Meds, and the code is NSI-CIP 057 at Meds. So Cipladon Plus is available at Meds. Right, so the antihistamine in Cipladon Plus, it actually blocks the GABA reuptake, resulting in a calming sedative effect.
All right, thank you for that.
Yeah.
So I think we don't have any more questions. Maybe I'd like to just give an opportunity to Dr. Esther to just give a parting shot, and then we can next have Coletta before we move to the closing remarks.
So thank you so much for attending this session. I'm always happy to give sessions on pain management, and I'm happy that I received very good answers to my questions. This means that all the pain education we are doing is actually getting somewhere and influencing our practice. Please, when you see another session, join us. We'll be happy to educate you more on pain. And please remember, for moderate pain, we want to choose multimodal analgesics. The combination analgesics are the best. And I'm not just saying this because it's Cipladon Plus sponsoring the CME, but really, if you look at the principles that we have discussed this evening, all our answers were gearing there, that you need a weak opioid and paracetamol. So let us continue to keep our patients pain-free. Thank you.
All right, thank you so much, Doc. And I see there was someone who was asking if they could get your contact, maybe your email address. I don't know if it's okay to share. Dr. Esther?
Yes.
Would you be comfortable with there's someone who was asking for your email address?
Yes, please. Yes, no problem. And also, I've seen a lot of participants want us to share the slides. Please go ahead and share the slides. Thank you.
All right, thank you. Thank you for that. Coletta?
Okay. I have seen a question which I think it is important to answer. Is Cipladon Plus an effervescent tablet? No, it is not. It is an ordinary tablet. Unlike Cipladon, it is an ordinary tablet that you swallow with water. So my closing remarks today is we have a very beautiful product, and I am asking or requesting you to support us. So Cipladon Plus is available through our distributor Surgifarm and other partner distributors, Symbio, Transwide, Nila, Omira, Philmed, Makadara, Krishna, Eldohost, plus other wholesalers. So I would ask you, I am asking you to support us, and thank you for your time today. Thank you.
All right, thank you so much, Coletta, for that. And thank you to our speaker, Dr. Esther. So just before we close, we'll just have a few, I'd like to take you through a small presentation here. Just a moment. So for those who've not subscribed to the PPB portal, kindly do so. This is the keywords that you should use: moderate or pain. You should be able to get the event on the PPB portal. Just search for the word management of moderate pain and check on the correct dates. You should be able to get the correct event. Just the next thing is to remind you that we'll be having the World Patient Safety Day that will be happening on 17th of September. And tomorrow we'll be having a walk that has been organized by CAPI. So for those who are available, kindly check out the posters that have been shared on your WhatsApp and join us to celebrate that event. And then the other thing is there's a Google form that has been shared. If you have any message that you'd like to share to the world about the whole patient safety, kindly do so. Submit your insights on the Google form, and we'll be able to put it in a poster like the above, and then share it on our social media for the campaign. Then the other thing is World Pharmacist Day is almost here, and it will be on 25th. And we have two activities that have been planned for the World Pharmacist Day. On 23rd, we'll be having the Inter-University Challenge at Kabarak. So for those who are interested in joining us to go to Kabarak, we have a charge of 1,000 shillings, which will include the transport. For now, the camping has been postponed. So we'll just have the day trip where we'll go all the way to Kabarak, then come back on the same day. And the charge is just 1,000 shillings. So we have limited slots. So kindly reach out to communications and we should be able to share more information about it. Then the other event is the speed networking event that will be happening at Harley's. And this is going to involve 30 pharmacists, senior pharmacists, and 30 young pharmacists. So for those who are also interested, kindly contact us. Then finally, on the last newsletter we had, there was a poster about winning a BP machine, and we had some entries. So today we are going to see who's going to win the BP machine. And how we are going to do it is we'll be using this platform called Wheel of Names. So if you'll just allow me, let me share my screen so that we can just quickly do the spin so that we know who won the BP machine. So these are the registration numbers of those who participated. The exercise was simple. You are just supposed to send your registration number to the communications number, and then we identify who's going to win. So just before we get started, I'll just do a shuffle of all the registration numbers that we received. So I think we've done the shuffle. So I'm just going to click on spin, and it's going to identify who is going to win the BP machine that is courtesy of CAM Pharmacy. So let's see. Okay, so we have a winner, registration number 807, which I think is also the oldest pharmacist we have among these registration numbers. So this is our winner. Maybe Miles, can you hear me?
Yes, Dr. Hezron.
Yeah, so maybe you could let us know whose registration number 807.
Our winner is Dr. John Jenga Ngeve.
Ah, nice. So congratulations, Dr. John Ngeve. We'll see how we'll communicate on how you're going to get the BP machine. So for those who are able to, you can just maybe clap using the app. Right, thank you so much. So for this coming month, the end of this month, we'll be having we are rolling out another call for articles, and this is going to go out in the end of this month. So if you have any articles, kindly share with us. Submit your articles to communications@psk.or.ke, and please have a maximum of 300 words. Remember, this is a small newsletter; it's not a magazine. So kindly share your articles to communications@psk.or.ke. The deadline for sharing the articles is 28th September. So kindly remember that. And the other thing is for the newsletter, we now have an opportunity to advertise our businesses. So whatever business you're running, you have an opportunity to advertise. So if you have any questions about advertising, kindly contact us communications@psk.or.ke. So an example of an advert is this one that was done. So you can all take advantage of that. Thank you so much. That is the end of my presentation. I'd like to once again thank our speaker today, Dr. Esther, and our supporters, our sponsors for this session. CIPLA, thank you so much. Coletta, Dr. Timothy, Dr. Maureen Waweru, and the entire CIPLA team. Thank you so much for the support. And we're looking forward to having more sessions with you. And for everyone who joined us today, thank you so much and have a good evening.